Right, let's get going. Good evening, everybody, and welcome to our OCL Vision Webinar by Sally Ameen. So this is the last in our current cycle of CET webinars. So from now on, we'll be going into CPD webinars, which will be starting next year. And I just wanted to take this opportunity to thank everyone who has joined in for all the webinars in the CET when we first started. That was during the very first lockdown when we had our lockdown webinars, and it's just grown and grown since then, and they've become very popular. So thank you to all of you who have supported us and joined us for all of them. And obviously thank you to all the consultants who have given us their time to talk about some really interesting topics. So just a little bit of housekeeping. This webinar is recorded and all our OCL Vision webinars are available to view on our YouTube channel, OCL Vision. There is one CET point available for this, and that's for optometrists, dispensing opticians, and contact lens opticians. And that's if you have joined using the link that you received when you registered for the webinar. So tonight's speaker is Sally Ameen. Sally is a consultant ophthalmic surgeon with us at OCL Vision and also at London's Imperial College Healthcare NHS Trust. She's an expert in the management of all forms of glaucoma and a specialist eye surgeon that performs all glaucoma surgery and is highly trained in complex cataract surgery and emergency ophthalmology. Sally, over to you.
Thank you so much, Bobby, and thank you again, everybody, for joining us this evening. So as the talk, which I am hoping to share with you now, the title that you have seen is about visual fields. So if you just bear with me a minute to make sure that it's all shared just there. So the objectives of the talk today is actually to start right back to the basics and explain the theory behind perimetry and visual field testing, how to analyze a visual field and look at the progression and the way to assess that, and how do the visual fields actually affect patient management, and we'll be looking at that through clinical scenarios at the end of the talk. So away we go. So if we just start with what actually a visual field is, and it was described by a actually Scottish ophthalmologist back in the 1800s as an island of vision surrounded by a sea of darkness, and also have been pictured as a hill of vision with a peak at the fovea, and it tapers down steeply nasally and more gradually temporally. Now, normal visual field extends 60 degrees superiorly and nasally, 80 inferiorly, and 90 temporally. And the blind spot is 10 to 20 degrees temporally, which marks the entry of the optic nerve into the eye. What is actually, what does perimetry actually mean? It is a formal evaluation of a person's visual field. And there are ways of measuring it, objective and subjective, starting with the simplest form of confrontational visual fields. And as you can imagine, that's quite an subjective measure of visual field, where you use your own visual field to compare to the patient or the subject that you are testing. NAMSA grid, that mainly assesses the macula or the central part of the visual field. Kinetic perimetry, which is very much operator dependent, and that relies on moving a target of different illumination and size and mapping out the visual field. And static perimetry, and that's one that probably most of us are familiar with and what we're going to be focusing on today. So the static perimetry, the kind of methodology behind it, it relies on the fact that the human vision system is adapted to perceive contrast versus magnitude of light. So it can be assessed by estimating the differential light sensitivity to a stimulus against a constant illuminated background. And it explores the different light sensitivities throughout the visual field, i.e. it will test each part of the visual field and mark and measure what the light intensity that is required in order for it to be seen at that test point. And the visibility of the stimulus depends on the intensity, the duration of exposure, the size of the stimulus, the color, as well as the background in which the test is being done, patient's attention, and any refractive error that may have. So what does that mean in practice? So it's you are presenting a static target, so the target does not move in any direction, and you are presenting it, it's consistent in size, but variable in its light intensity or luminance on a map of a visual field. The luminance determines then a threshold, and then we'll go on to talk about what a threshold value is, for retinal sensitivity at the different test points, and then it creates the visual field map for you. And then with the machines that we have available, they have preset programs that can measure the boundaries of a visual field. Such example, the one that's mainly used in clinical practice by most clinicians in hospital settings is a Humphreys visual field. And that's also the one that's used in pretty much all the clinical trials. One point that I wanted to make right now when it comes to visual field, I kind of played around of where to insert this point, but just keep in mind that actually what a visual field is a region of space that is seen without movement of the head. So in reality, what it ends up being is actually the mirror image of the actual retina. So the image is left to right and inverted top and bottom. And when we look at the clinical scenarios, this will become more important and more visible to explain. So what does a threshold actually mean versus suprathreshold and infrathreshold? Threshold is the value at which 50% of the presented stimulus is actually seen by the patient. Superthreshold is when more than 50% is seen, and subthreshold is when less than 50% is seen. And like I said, the main value that we're focusing on is essentially the threshold value, and that's the one that gets measured and tested in the visual field assessment. How do you actually work out that value? Because obviously it's different from person to person, from one test point to the other test point. And then basically what the machines do is they use a bracketing system to work out the value. So they find the subthreshold value. And if we go back again, so that's basically the one where less than 50% are seen. And then it starts increasing the light intensity by 2 to 4 decibels until you find the first point, and that's your first crossing of the threshold, and then decreasing it slowly until it's no longer seen, and that is the second point of the threshold, and therefore the threshold value lies between those two marker points. You'll have to test at least 5 stimuli in each test points. And then you can adjust the starting point, adjusting it to what's expected for the age for that person and with their visual acuity. And you can also use it by looking at adjacent test points and what you expect the patient to see. But that, as you can imagine, can induce bias. So then that leads us on to the next point that I'm sure a lot of you have seen when it comes to visual fields, which is CETA, and that refers to Swedish Interactive Threshold Algorithm. And you can have CETA standard versus CETA fast. And what it does, it starts by threshold values at 4 primary points, and then it calculates the starter level of the adjacent points based on those 4 points. And they are presented in pseudo-random order, and the patient response time is also taken into account in order to work out the time intervals between the stimuli. The difference between the CETA standard and the CETA fast, as the name suggests, is the faster setting goes quicker, but sometimes is not very useful for elderly patients or those who might have slow reflexes. So in most cases, the CETA standard examination is the one that's used. Now, why do we actually do it? Why don't we just test at each point as you would expect? Because as you can imagine, if you do just the full threshold, it can show you here, it takes 14 minutes. And if you go all the way down to the CETA fast, it takes merely 3 minutes. That's not just to utilize on the time of the actual machinery that you have available, but also on the patient's concentration. As you can imagine, in most cases, you'll be examining 2 eyes at the same time. Now, if it's taking you half an hour to do the test, the patient does lose concentration, and therefore the quality of the test that you'll be doing will be less than it would if it's expedited. This refers to the size of the visual field that gets tested, but we will go on to that very soon. Next, so the test patterns that we have available are 30-2 versus 24-2 versus 10-2 versus the macular function. The 30-2 tests 76 test points, 30 degrees from fixation, as the name suggests. The 24-2, which is the one that's most commonly used in actual clinical examination, tests 54 test points, and these are the extensions at which it does it. So more nasally than superiorly and temporally. The 10-2 is really mainly reserved for patients with severe visual field loss. We're actually doing a wider visual field. If you already know that the visual field has been damaged, it's completely useless. as you can see, still has quite a lot of test points at 68, but it only focuses on the central 10 degrees, of the actual visual field. The variables during the visual field testing: the size of the stimulus. For most times, the Humphreys visual field uses size 3, which basically refers to the diameter of the actual stimulus size. The duration, again, in most part, is 200 milliseconds for the Humphreys visual field, with a background illumination of 31.5 units of light. So these are preset in most tests, but again, we will look at those when we look at examples of actual visual fields. So now to get down to the technical stuff. So I'm sure many of you have seen this before, and this is essentially a printout of a Humphreys visual field for a patient. As you can see, the slide is quite busy with lots of little arrows and boxes trying to explain what's what. So if we just start by what do you do when you first get faced with one of these visual fields? So I'll keep reverting back to that slide just to make sure we cover all the bases. Sounds very simple, but actually always check that you have the correct patient, because with everything that goes on all the time, there's always room for error. And then actually you might simply be looking at the wrong visual field for that particular patient. And then you assess the parameters that you have available. So the false positive, the false negative, and the gaze tracker. So if I just take you back here, and these are the readings that you have here, or the reliability indices that I have written on here. So the false positive is your trigger happy patient. So this is a patient that just keeps pressing the button all the time. And the machine tests it by essentially putting up a value that it knows the patient shouldn't be seeing, and seeing how they respond to it. The false negative is the exact opposite. So these are the patients that essentially fall asleep, and I'm sure many of you have seen and heard about the cloverleaf distribution, where essentially what happens is they're awake for the beginning and they start fading away and falling asleep nearer to the periphery. And the way the machine detects that, again, is by essentially testing a point that it already has tested before and the patient was able to see, and then the second time the patient doesn't see it, and that shows a false negative result. Sorry, and if I just go back again, and you have the gaze tracker at the bottom, and that essentially tracks the eye movements throughout the test. Remember, as you know, the patient should be looking straight ahead and not trying to chase the dots of the test points all the way around. So those are your reliability indices. You've also checked that it's correct the patient and the type of test that you have. So as you can see on this one, it's a 24-2 test that's been carried out, and it is a CETA standard for that one. The age of the patient, essentially the date, and the visual acuity and any refractive error. Now the refractive error, the machine would ask you to correct it for distance visual acuity, and it will calibrate it to the correct amount to put in front of the eye. So that's again something to be aware of, because obviously it will lead to inaccuracies if that's not the one that's used. It will talk about the stimulus size, and this one says 3, and the background illumination that we've already talked about. And the length of time it took for the patient to carry out the test also gives an indication of how well they did. So those are your first starting points. It kind of just gives you an idea of how useful really that visual field is going to be, because if it already has lots of false positive and false negative, and the gaze tracker showing that the movement is all over the place, it already probably does mean it may not be the most accurate, but it will give you some useful information nonetheless. So the next thing that you'd look at, which everybody always looks at right at the start, is the grayscale and the numerical values. So that's essentially looking at the grayscale here and the numerical value plot alongside it. And what does that actually really mean? So the numerical value is a threshold sensitivity at each test points in decibels, and they range between 0 to 50, with 0 being the brightest and 50 being the dimmest. A value of 0 means the patient could not see the brightest target, and 50 saw that the dimmest target. Most values are usually around 30, and the grayscale essentially shows the value of closest to 0 being in black, and those closest to 50 to being in white. So again, if we go back to this, as you can see, this is black, and if you can see the correlating point to it, they are 0, but that's essentially your testing blind spot, and we know this is where the optic nerve enters into the back of the eye. And then the rest of it are the values that usually lie closer to 30. And that's the grayscale, which is as close to white as possible. So that's essentially what the grayscale means and the numerical value that go with it. The total deviation map is the next point that you look at, and that essentially represents the depression in the vision at each test point with an age match control, with a numerical value and a matching grayscale. So again, if we go back, we're talking about this one, the total deviation pattern. So how much away from what that patient was expected to be at were they off? And that tells you 0, -1, -10, -20, and then you have the matching grayscale to go with it. And the next point is the pattern deviation. Now that's quite interesting because it represents any focal depression in the area in the points that were tested, accounting for overall depression as estimated by the mean deviation. Again, you have a numerical value and a grayscale, and this identifies factors such as a global reduction in the visual acuity sensitivity in patients who have cataract, corneal opacity, vitreous opacity. So what you would see if a patient has a high total deviation loss due to, for essentially cataract, most of this test will be grey/black. And then when you take into account a global reduction, this one will be completely normal. So this will yield any kind of specific focal points where there is depression in the visual field. So far, that's where we've got to. And then the next point is the glaucoma hemifield test. What the machine does at that point, it compares the point in the upper field and matching them with the lower field. And it gives you 3 outcomes: outside normal limits, borderline, and within normal limits. And that's essentially referring to these values here, glaucoma hemifield test, or GHT, for what we have. The next value that we will be looking at is the numbers that you have in the bottom right-hand corner, which is the mean deviation versus the pattern standard deviation versus the visual field index. So the mean deviation calculated from the total deviation map, and the more negative, the more advanced the disease. The pattern standard deviation provides information about localized loss. So this is the number is positive in this case, and a high pattern standard deviation indicates a non-uniform sensitivity loss, i.e. it's not due to cataract or vitreal opacity. But just a point of note, in advanced glaucoma, you may find actually the PSD value looks like it's improving, but that's actually because there's a global depression in the entire visual field. So just be wary when it comes to looking at these values and comparing them. As you know, unless the cause of the visual field defect is reversible, which is not the case if it is glaucomatous, then these values should never be getting better. The best that we can hope for is they stay static and do not get worse. Now, the visual field index is a staging index to identify the amount of functional ganglion cells and total amount of visual field loss. 100% is a full visual field, and 0 essentially is perimetrically blind. So these are, to go back to our original chart, the values here. So that's the VFI there, the mean deviation, and the pattern standard deviation. Now, the mean deviation is used in pretty much all the glaucoma studies to assess the level of essentially severity of glaucoma to mild, moderate, and severe. 0 to 5 is mild, 5 to 10 is moderate, and anything greater between 10 to 15 is considered to be severe. And remember, these are negative values versus the PSD, which is a positive value. So that pretty much covers your visual field map when you look at it. And I hope then when you are now faced with the next visual field, it all makes a little bit more sense what all these values and what all the numbers really mean. Now, as a standalone visual field, it literally just gives you a snapshot of what's happening in the here and now. With most diseases, especially namely glaucoma, as we know, it is a progressive disease. So we do need to know how to assess visual field progression by comparing visual fields to the one prior to it in order to understand how the disease is getting on. You've got the subjective versus objective. As subjective suggests, simply you have the values and the probably 2 printouts of the visual fields next to each other. And you look at the numerical values and then you compare them and see if there's any progression. if you are going to do that, you have to ensure that all the parameters are assessed, just like we have just done. So ensure that the visual fields that are being compared to each other are as accurate as each other. There are no discrepancies. Nothing has happened to the patient in between that would explain the sudden change in visual field, so on and so forth. And ideally, you would have more than 2 visual fields to look at. And it's very difficult to assess progression really based on 2 tests. And that applies to pretty much all the investigations that we carry out. But sometimes that might be the only thing that you do have available. Now, the machines have been designed to create objective ways of measuring visual field progression. One of them is being the glaucoma progression analysis. And essentially what it looks like is it looks at the deterioration and the mean deviation from the baseline at each of the test point. So essentially, it is doing what you are doing with the naked eye, but more objectively and looking at all the numbers carefully. It will ultimately suggest whether progression is possible or no progression is noted. And the map essentially looks like this. So it has the list of the visual fields all put together, and it will give you essentially a suggestion or a recommendation at the bottom of that. And then again, you have to be a bit careful about, as with everything, people always say it's the quality of the data that goes in that will tell you how useful the information that comes out is. So if you don't have very reliable visual fields in the first instance, then this will be completely useless. So you just have to be careful about the selection of the visual field. And the machine does allow you to select appropriate visual fields. And again, just to give you an indication, when any trials are done looking at visual field progression, there's always a learning curve for the patients. And the first 3 visual fields that are done by the patients are normally not included in any further analysis of the disease, because there is a learning curve to doing these tests. And it does take them at least 3 to 4 goes to get as accurate with it as possible. So now if we move on to clinical scenarios to try and put it into practice. If we go back, if you cast your mind back to the original point that I made a while back about the reverse of the image of the visual field to actually what's happening in clinical scenarios. So this is a patient with a glaucomatous disc damage. There is a loss of the inferior rim, and therefore mainly the visual field loss is superiorly. So that's just, again, when you are looking at the visual field, it's not just the field on its own, but it's the clinical picture and see how well it fits together. And as we go on through these clinical scenarios, just to give you an idea about reality versus textbook, and then we'll talk about them as we go along. So that's just your classic inferior loss of REM, superior loss of visual field, and essentially advanced disease. As you can see here, the mean deviation is -12 with a PSD of 12.25. The parameters of the test are quite good, very little false positive. So anything less than 5% is very good. And the same again with the false negative. Very little fixation losses, any 2 out of 19, same as standard size of the stimulus and the light and the background lighting. And it's a CETA standard. The correct refraction error and the visual acuity was done appropriately, and also tells you size of the diameter of the test, age of the patient, so on, etc. And it's a 24-2. So that's all perfect clinical picture. The next one that I wanted to show you is a patient that was referred to me with possible, as you can see, visual field loss superiorly. Now, this gentleman has a very strong history of family history of glaucoma. All of his elderly siblings, as well as both sets of parents, have quite severe glaucoma that have required surgical correction or treatment for their glaucoma. So as you can appreciate, he's very anxious, and that's the actual visual field that came in the referral letter with essentially normal intraocular pressures. So you can completely understand why this patient was very concerned and very worried. So in the first instance, this is the visual field that we were presented with, and actually the parameters don't look terrible. Sorry, my lighting is not great, but all in all, it looks like a fairly reliable visual field. He does have some false negative at 9%, but no false positives. So obviously he's not trigger happy, and it's all focused superiorly. So on examination, when the patient comes, this is actually the scan of his optic nerve head, as you can see. So this is all referring to the right eye. So, you know, he has a large optic nerve, which, you know, cup disc ratio is quite high. It is 0.7. But actually, if you look at the nerve fiber layer measurement, he's got a fairly healthy nerve fiber layer, both in the right and the left eye, with a healthy distribution all the way around. So that was quite reassuring. So the first thing that we did is we repeated this visual field test. And as you can see, now the false negative has gone down to 0. Pretty much that visual field defect there at the top was gone. And actually what was happening, despite the fact that he was quite young, he did have a little bit of litosis, and simply just by lifting the lid or asking him to keep his eyes open all the time, he did much better. So even though the gaze tracker does show that his eye moved around quite a bit, he didn't have any fixation losses, and actually he did the tests very well. So now this patient was reassured, and at the moment we're still going to monitor him because essentially of his very strong family history, and understandably he's very anxious, but crisis averted for him. So the next clinical scenario, just to make sure that I am on the same case, is probably the opposite. So this was an elderly gentleman that was referred in with essentially query glaucoma. He has known history of pseudoexfoliation, but now is pseudophakic, never really had any high pressures with the pseudoexfoliation, and there's no family history that he knows of glaucoma. So the optic nerve scan does show a healthy nerve fiber layer in both the eyes, with, you know, a slight disparity in the cup disc ratio, with it being high in the right in comparison to the left. And maybe with the CGG, there is loss of nerve fiber on that side, but nothing really untoward. And like I said, the pressures were normal. But this was his actual visual field. So as you can see, there's this paracentral loss. But again, if you look at all the parameters again, the gaze tracker was all over the place. The fixation losses shows 6 out of 11, even though he really didn't have any false positive or false negative results. And the rest of the parameters are like the ones that were tested before. So it's really, what do you do with that patient now? Because he has normal pressures, he has essentially what looks like a healthy optic disc, nothing that's worrying, but he has this query visual field defect. And unfortunately, you will be faced with this day in and day out on a regular basis, because unfortunately the world is not textbook, and the picture doesn't fit together. And then that's when you have to remember that it's the whole picture and not just a visual field that can help you make the diagnosis and make the ultimate plan. And actually what we agreed with this patient is to actively monitor for now. He is 87. The other eye is completely fine, and actually people have tried to give him drops before, and that's the reason why he came to see me in the first place, because he's allergic to pretty much all medication, including preservative-free drops, and he was really suffering and really struggling, and endless visits, worried about getting COVID, coming into a big hospital, etc. And we agreed to actually stop all treatment and essentially watch. And you can see even here it says it's a low test reliability. With those patients, need to leave at least 4 months interval before you repeat the visual field test. If you do it any sooner, it's unlikely to be much different, even if there is a true progression of visual field defect. And we know that with glaucoma, it can happen even with normal pressures, with normal pressure glaucoma, and that gives you paracentral visual field loss. But you do need to give it some time, because if you see them too soon, there's not going to be any real change on the visual field, and there's not going to be much change on the OCT, and the field will probably still be unreliable. So for this particular patient, I would just monitor for now without any real treatment. So the next patient is a lovely young lady who essentially, as you can see, I saw today in the clinic, and this is her disc OCT. So as you can see, there's already quite a bit of damage going temporally, starting superiorly and inferiorly, as well as nasally. The other eye pretty much looks exactly the same. When you look at this optic disc, you're worried that essentially she's wiped out pretty much most of her visual field, and actually her pressure was 35 on oral Diamox as well. So, you know, it's really scary, especially for a young patient, when your starting point is this. You know, this lady is only 28, so she's going to be living with this disease for a long period of time. But actually, this was her visual field today. So despite the disc looking as horrible as it is, despite her pressure being as awful as it is, in reality, from her point of view, from her day-to-day living, which is ultimately what this is all about, she's got minimal field loss superiorly. And again, the test wasn't the most accurate. She had some false negative, a few false positives, and it's all centered at the top, which doesn't quite fit with her disc OCT, because superiorly and inferiorly her disc is still sort of okay. It's mainly temporally and nasally where the disease has progressed. But again, like I said, the world is not textbook fit. But that's reassuring, because when it comes to management of these patients and planning for essentially surgical intervention, when you look at this and, you know, we're getting closer and closer to Christmas and the patient's really asking you to try and hold off as much as possible, you can probably breathe a slight sigh of relief and think, okay, time's on our hand, we can wait a little bit, and then address this very soon. Now, this patient is also someone that I met today. And again, if you look at the optic disc, the main issue is superiorly. So you would assume if they were going to have any kind of visual field defect, it would be inferiorly. Actually, their visual field, again, not the most accurate. They did have quite a bit of fixation losses, 7 out of 10 with false positive and false negative. And it does tell you the test is not very reliable. So not ideal, and you have to take it with a pinch of salt, but still very useful in the sense to show that actually the visual field is quite full. And then that goes back to the point of pre-perimetric glaucoma, which is something that's become more and more common, especially with the new OCT scanners that are available. You need to lose about 50% of the nerve fiber layer before you develop an actually visual field defect. And this is quite important, because with all the gadgets and the toys that we have, we now can detect glaucoma before it becomes problematic to the patient and prevent them from having any real visual field defect that can impact on their day-to-day living. So again, this is a gentleman that came in, pressure was above normal on topical treatment with a double agent. Their pressure was running at 28, despite them being on COSOPT. He hated the drop, made the eye very stingy, very uncomfortable. People started talking to him about surgical intervention very early on. The vision is 6.6. He otherwise is completely fit and well, and he's in his 50s, so he's quite young, 59 just there. So again, when you look at that visual field, you know you've got more room for maneuver before you start talking about surgical intervention, but you can see there is some disc damage. And again, once you get more disc OCT pictures and you can look at progression, you can show the patient if there's any real change, and you can talk about treatment accordingly. So you don't just treat the disc OCT, you don't just treat the field, and you don't just treat the pressure. You put them all together, you put the patient in front of you, and you choose the appropriate treatment for that patient. And each piece of this jigsaw fitted together will give you the best idea when it comes to how best to manage these patients. This is just to show severe visual field loss from previous retinal laser. So in the past, as you know, with PRP laser, people used to do it quite aggressively. There was a lot of destruction of the peripheral retina to the extent that the patient were literally left with a small island of vision. Thankfully, this is now very rare and hardly ever seen. And actually other causes of visual field changes. So obviously it's not all glaucoma. You see this is a patient with bilateral swollen disc. And the main thing that you see on the visual field is essentially the enlarged blind spot. And what's interesting about this, again, if you look at the mean deviation pattern versus the pattern deviation, there's a global reduction in the whole visual field. But actually, when you look at the pattern deviation, the main focal area where there is extensive loss is at the blind spot. And the rest of the chart is actually absolutely fine. And the final thing that I wanted to show is to remind people, it's not just the size of the visual field defect that's important, but it's also the location. So this is a fairly young patient who unfortunately ended up having a paracentral, very close visual field defect, and the vision suddenly dropped from 6.5 to 6.24, 6.36, because it just really, they were very unlucky and very unfortunate as they lost the visual field right in the center. So this is a very accurate visual field, and unfortunately this is very true, and it has impacted severely on their vision. So it's very important to try and pick up and detect any early changes, and if you think there's any evidence of visual field progression or visual field changes, to try and halt them and deal with them as soon as possible. And that's pretty much it for today. Thank you very much for listening. I hope I didn't take up too much of your time, and I hope you found it useful, and I'm very happy to take on questions. Thank you.
Thank you so much, Sally. That was absolutely fantastic. I've learned so much about visual fields. Looking forward to picking your brains when I see you in clinic. Right, so here we go with the questions. Are you ready?
Yep.
There was one question earlier on, actually, you talked about the visual fields and the prescription that you put in. And we know we have to put in the near correction.
Yeah.
When you enter it into the Humphreys, do you put in their distance RX?
You do. Yeah, I checked that today. You do put in your, I know, I found that very bizarre as well, but actually you put in the distance correction and somehow it converts it into the near. Okay. So yeah, I mean, you guys do this a lot more than I do, but I double checked it today and went downstairs and looked at the visual field machine, but apparently that's what happens, which is interesting. It was interesting for me as well.
Sally, when should we do the C40 testing, and when should we do the 24-2 testing or 32 testing? How do we know which one we're meant to choose?
So for most times, the 24-2 is more than sufficient, because actually the 30-2 is usually done either for insurance purposes. You can assume there are things like, sorry, I'll stop sharing my screen. You don't need to look at that anymore. You know, for insurance reasons, there are probably certain vocations that require to do a 30-2, like pilots, for instance, and things like that. The 10-2 is for those with severe visual loss. So say you already know that this patient has very advanced glaucoma, there is no point subjecting them to a 24-2. It gets very frustrating for the patient when they're sitting there. They know that the test is going on and they'll be sitting there for 2 minutes, which is actually a very long time when you're just sitting with nothing happening. So that's for severe disease. And like I said, for most cases, the 24-2 is the one that's very suitable. It's suitable in terms of the size of the visual field and the length of time that it actually takes to do it.
And the C40?
I don't think I've ever seen a C40, to be honest. The commonest ones that people use are the 30-2, but like I said, that's mainly reserved for any kind of particular reasons. The 24-2 is the commonest one, and the 10-2 is for severe visual field loss for whatever reason. I mean, this doesn't have to be glaucoma. And
just going over the 24-2 CETA fast versus a standard?
For most cases, actually, the CETA standard is absolutely fine. The CETA fast, as the name suggests, is fast, and sometimes it is too fast in their testing point. So instead of testing, you know how we talked about the pseudo-random pattern where it will test, the CETA standard will test these points, and then it knows that you can see that, and then it randomly goes somewhere else. The fast will literally test the point for a shorter period of time. So it's 100 milliseconds instead of the 200. And then the patient gets very confused and they're not quite sure if they saw it or they didn't see it. And so the duration is one thing, and it's much fewer test points. So actually, if you miss one point, it ends up being completely black, but actually it might have just been simply, it was just too quick for you to see. So for most cases, the CETA standard is the one to go for. The CETA fast is probably quite useful for screening, for instance. So if you literally just want to do a very quick 2-minute visual field test just to get a global idea, and you know the patient is going to be fine doing it, so they're young, they've got good visual acuity, good reflexes, then that's one to go for.
Thank you. Sally, there's a question about the case study you showed with the chap with the ptosis.
Oh, yeah.
So someone's just asked, which I'm sure a lot of people are confused about, is that whether there's ptosis, when some of the superior visual field will be affected. They're a little bit confused with the visual field being opposite to the retina location. So if there is ptosis, should you see an inferior visual field loss, or is it just the superior?
No, because that's mechanical. Yeah, I see what you mean, but no, actually ptosis is just mechanical. It's just that's the bit that they're not seeing there and then.
Perfect, thank you.
That's a real one.
Sally, a question about the repeating measuring of fields after 4 months.
Yeah.
So is this under the care of an ophthalmologist, or is that, can an optometrist also require repeat field in 4 months, or are we leaving it too long?
No, so that's always the issue with these things. So people get very twitchy when you find an abnormality, and correctly so. I completely understand why people get uncomfortable when you see something abnormal. But if you test it too soon, and it's, for instance, let's say this is normal tension glaucoma, and it's simply, the disc is okay, and the pressure is okay. The reason why I'm saying leave it longer is actually the disc is okay. If there was evidence that actually this visual field defect correlates with the optic nerve, then you think fine. But an elderly patient where the field is not very reliable and you're thinking possibly this could be normal tension glaucoma. Normal tension glaucoma is very slow in its progression. It literally takes up to about a year, unless something else is going on, for you to notice something. So if you repeat it too soon, then it's not going to be very useful for yourself or the patient, because it will either look the same because the disc wouldn't have had a chance to get damaged further. Not that you want discs to get damaged further, but to the point that you can objectively measure it. And unless, on the day that you did that visual field, there was an obvious reason why they had that defect, they weren't concentrating, the glasses were in the wrong place, etc., etc. Then if you're happy with the test that you've done, you do need to give it that length of time. Now, in terms of who does it, I'm very appreciative of the fact that optometrists, and correctly say, get very nervous about holding on to patients where the results are not pristine and perfect. And there's kind of like two ways to do this, and it depends on the unit. And we're still in sort of COVID era, and there's long waiting times, especially on the NHS, to see these patients. Is a lot of the current eye units are trying to have a kind of an open dialogue with their optoms, where you can physically send things in and someone has a look at them and says, no, this is okay. Or the alternative, if that's not available, it should still ideally be under an ophthalmologist so they can have a look at it, monitor it, and then assess. You kind of get an eye for these things, and you get a gut feeling of how much of this is actually real and how much of this can be left alone. And again, if you're not happy keeping it, then the safest thing is to send it on and refer it on to an ophthalmologist.
Thanks, Sally. We do have a lot of questions coming in.
Sorry.
Try and get through as many as we can. No, they're great. Should we be doing CETA tests for all fields, even if not suspecting glaucoma?
Ideally, yes. Basically, if you look at the NICE guidelines about glaucoma and the definition, it always talks about Humphrey's visual field, and then the CETA standard is the one that everybody tends to go to, because when these patients are referred in with non-Humphrey's visual field, the first thing that gets done is a repeat of that visual field to see really if there's anything else going on or not. But by definition, glaucoma is optic nerve neuropathy or loss of nerve fiber layer with a corresponding visual field defect. So you do need to have a formal visual field defect, and the ideal one is Humphrey's.
How about for screening purposes? Obviously, a lot of practices just have some visual field
screening.
screening.
That's fine. For screening, I think it's absolutely fine. Unless you have a high suspicion, say, for instance, this patient with high pressure, a patient with an optic disc that just doesn't quite look right. If it's everything else is absolutely fine and it's purely to tick the box of screening, then no, you don't really need that.
Just a few more, let's go for it. So if we do the visual fields and we find a defect, should we repeat it first before we send it in?
Again, so this was the reason for all the examples. A visual field on its own, that's why you kind of need to make sure that the field that you've done was good enough to explain the result that you got. Because if you look at all the indices and the false positive everywhere, false negative everywhere, gaze trackers everywhere, and the patient was just awful at doing it, then it's simply a visual field. The issue is not actually anything anatomical. It's most likely because the patient didn't do the best visual field that they can. If that's the answer, then yes, absolutely repeat before you move on. If it's a very accurate visual field, and you can't explain why it's there, or it's not already established, because sometimes you get a new patient as an optometrist, but they are known to either have glaucoma or a macular disease or something that would explain that visual field defect. So if it's a new onset visual field, then yes, it does need to be referred on. So an accurate visual field with new onset, even if you can identify the cause, so say you then have a disc OCT that confirms the cause of it, or you do a macular scan and it shows changes on there, then they do need to be referred on. But in the first instance, which is the whole point of this talk, is knowing how to interpret that visual field test that you've done and being comfortable in saying, yes, this is a true defect versus this is an artifact.
Okay, that's great. So moving on to the next question, someone has mentioned that the visual fields and reliability, often patients, they are trigger happy or they fall asleep, and and it's really difficult to make it repeatable. Isn't OCT enough?
Yes, so we go back to this point, which was the reason why I showed that scan of that elderly gentleman. He's 87. He's not going to be good to do a visual field. And actually, in some patients, you simply don't do visual fields because it's just very stressful for the patient. It doesn't yield any useful clinical information, and you monitor them based on their OCT and their IOP. So yes, that's absolutely fine. So if you have a normal OCT and a normal pressure, but a visual field that's simply inaccurate, then that's absolutely fine. If you can justify why this field this looks awful, then yeah, that's absolutely fine.
And then the question of OCT, how about if we have a tilted disc versus a glaucomatous disc? Can an OCT show it, or do we just have to
Not really.
look?
No, they don't. I mean, that's one of the big fail points. The only interesting thing to say about that is, again, we talk about progression versus static. If it's simply a tilted disc and, on the first original scan, everything looks a bit mismatched, it's not going to change. It will look exactly, it will look bad, but the same on repeated scans. If it is glaucoma, it will progress, because essentially glaucoma is a progressive disease. And sometimes actually that is the only way to tell. There are some patients who are so myopic, actually an OCT is completely useless. And again, we go back to the point that real life is not textbook. And that's when you kind of get a gut feeling about these things, when you've seen enough of them that you can tell the difference. And actually we do tell the patient that, for you, unfortunately, we can't monitor you by the standard ways that we'd monitor someone with glaucoma, and we just have to rely on other indices.
So as an optometrist in High Street, I have to say, when we have these patients coming in and we think, oh, is this a tilted disc or is it not? If we can't tell, or if you find it difficult to tell with these, do we refer them? Because if we wait 4 months to repeat it and then the defect's progressed, are we going to get in trouble for missing it?
I don't think you'll get in trouble for missing it. I think, the simple answer is it's much easier to refer on something and then get an answer back saying, no, this is absolutely fine. And again, with experience, then you guys will get comfortable of, like, you can refer to point A, point B to say, actually, this looks like person X, Y, and Z, where they've gone back. And you can actually say to the patient, have a very honest conversation, say, your scans haven't come back normal, but I think they are justifiable by that. The two options are, we refer you on for a second opinion, or we can monitor you and see you again in about 4 to 6 months' time. And I think most people are quite reasonable. I think the only thing why I'm saying not just refer anything, I'm just very conscious of the fact, and I'm sure everybody else is, with COVID and everything that's going on, the waiting times are horrendous, actually privately or NHS. And sometimes patients do get very anxious when you say to them, there is a problem here, when there may not be. So it's always this balance of probability about who do you really send in. But again, the gut feeling is, if you're not comfortable and you're not happy, it's much better to send it and come back and be told this is absolutely fine than miss something.
A really interesting question here, Sally. So sometimes when we do our visual fields and a patient misses a few spots, we ask them to repeat it and they come back and they see other spots that they missed the second time. They all
do that.
They do. But if they've seen the original spots that they missed, are they clear? Have they just missed different spots, but overall they've seen them all?
Basically, yeah.
That's not just a funny glaucoma kind of.
No, it's not. That's just them concentrating on different spots at different times. It's very annoying when they do that. And they come back and you're like, you just repeat the field and then you'll be okay. And then they find a new thing and you think, really?
Great. If we detect a visual field loss, how soon do we have to send them in?
It depends on the severity of the visual field and the other factors involved. So again, sorry, my head always goes back to glaucoma. So if we're talking about a glaucoma patient, if the pressure is completely normal, the disc is fairly healthy, and it's just the visual field that you're questioning, that's a routine referral. 4 to 6 months is actually absolutely fine. If the pressure is high, it's a very suspicious optic disc, strong family history, this is someone that needs to be seen usually within 2 months maximum. So I
wonder if you'll know this one. Can you explain what the number 2 means in 24-2, 32?
I don't know. No, I looked that up as well. I couldn't find it anywhere. I might actually have to look for it again and then answer that question.
I wonder if it's something to do with the step process.
It must be. That's my homework for tonight.
Sally, if someone misses a lot of points in the CETA standard, 24-2, and the results are reliable, for repeat visual field, should they go 24-2 again or go 32?
I'm not sure, but repeat the question.
So if someone's coming for visual field, we've done a 24-2 and there's some spots missing, so we call them back and repeat it. Do we repeat exactly the same scan?
Exactly the same. Yeah, no, exactly the same. Yeah, because they have to be comparative. If you do a different scan and they do better or they do worse, or like, is it because you've done a different scan, or is it actually because they are better or worse?
Sally, what's the best visual fields test for detecting papilledema?
Goldman, actually. a Goldman visual field is the best one at detecting back papilla edema. The problem with the Goldman is it's a dying art, unfortunately. It's not something that everybody does. The machine itself, I think, I'm not sure, I think it's been discontinued. There aren't that many of them around in the country. Have you ever seen a Goldman visual field being done or done one? Yeah. I know. I remember as a kind of a junior trainee, very fascinated by the fact that there's this person with circles going around and loops, and you're like, wow, this is very fascinating. But yeah, for neurological disorders, actually a Goldman visual field is much better, because if you remember, it tests the size of the stimulus, because they change the size as well as the color, which essentially is the illumination. So they may be able to see a bigger target than they would a smaller target. So it's more sensitive for neurological disease.
And in the high street?
I guess it will have to be a Humphreys.
And with the 10-2 or?
No, the 24-2 will be absolutely fine as well.
Okay, should we go for a couple more and then we'll log off? So
Sure.
Sally, I mean, I've still got questions about the prescription, and I believe, if I'm just going to summarize, you put their age in, you put their distance RX in, and the visual field machine will tell you what prescription, what lens to put in, which will be for their near power.
Absolutely.
So essentially you're putting the near power in, but what you're inputting is the distance, correct?
Yes.
And a few questions.
If I'm wrong, then you have to shout at our technician.
You're not wrong.
Because I went downstairs and we had 10 patients today, and that's what they had, and they all came out accurate. So I think I'm hoping that's correct.
You're not wrong. How about false positives, false negatives? What numbers do we say?
Anything above 5% you take with a pinch of salt. Anything above 10% in either of these parameters pretty much tells you this is a very unreliable visual field.
Okay. How about probably one last question, actually, maybe one of the last ones. When reviewing the 24-2 for glaucoma monitoring, would you say changes in the mean deviation or pattern standard deviation is most useful for detecting the earliest changing? Or do you look at them both?
You would look at them both. And again, you would look at the whole test, not just these two values. So it's an interesting thing, actually, because in all the studies looking at any kind of glaucoma disease, they always look at the mean deviation to assess progression, not the pattern standard deviation. I'm not sure why, because you would think the pattern standard deviation is more accurate. I think it's all got to do with the fact that actually, even with more advanced disease, what happens is, because the entire visual field then goes down, the pattern standard deviation is susceptible to being less accurate, whereas the mean deviation is a solid value all the way throughout, even if it doesn't account for any global reduction in the visual field. But yes, when you are looking at them for glaucoma monitoring, ideally you would use any kind of objective progressor that you have built into your system to kind of give you an idea about whether or not the field is progressing. But yeah, either value or both. Great.
Sally, should we leave that there? We do have a lot of questions, actually. So if anyone does have any questions that they really would like Sally to answer, feel free to email them to me or pop them on the WhatsApp group in the WhatsApp group, and I will get them over to Sally. Or Sally, you can answer them all on the WhatsApp group.
Do my best.
We have an answer for the 24-2. Are you ready for this? Thank you, Susie, for this. I'm going to read it out.
Yeah.
The second number on the test, the 2 came about because it was a second pattern for the threshold test that was developed.
Okay.
The first pattern is known as the 31 and 24-1 and differs primarily by whether stimuli are presented. It goes on. Susie, thank you for this. If I read it out, I think I might put everyone to sleep. So if someone does have a question about this, maybe we'll pop something in the WhatsApp group, Sally, once you've read about it.
I've read about it and then try and summarize it. Absolutely.
So yeah, so lots of people have answered this, so thank you for that. Right, Sally, I'm just going to host a poll, actually. So if everyone could just fill in the answers to the poll. It's been an absolutely fantastic webinar, Sally. I can tell by the amount of questions we've had, and the feedback already has been brilliant. Any last words from you?
No, thank you very much, guys. It's always very difficult. I mean, I was telling Purvi about this before, choosing a topic that hopefully is useful as well as interesting and clinically useful as well as educationally useful. So hopefully this was, and thank you again for joining. Have a lovely Christmas and a very happy New Year. And any other questions that weren't answered today, more than happy to answer them for you. Thank you again. Thank you so much, Sally. I'm just going to wait for another 15% of people to answer the vote. That would be great. So like I mentioned earlier, this is the last of our CET cycle. From next year, everything changes. When it does, I will be in touch with you just to let you know how everything runs and how things are going to go from an OCL Vision webinar perspective. Hopefully not too much will change from our end, but perhaps more will have to change from us as optometrists.
in the way we receive our points, but I'll be in touch with everyone about that. And that's all it. So everyone, I'm going to end the poll now. Thank you so much for joining us, and it's been an absolute pleasure. Have a great festive period, a happy Christmas, and have a great new year. And we'll see you back next year. Thanks, Sally.
Thank you. Thanks, guys. Good night.